Bilaspur, and she has many accolades to her credit. So over to Dr. Kalpana.
Thank you, sir. Thank you very much. Let me just share my slide. Can you see my slides?
Not
Not yet, ma'am. Not shared.
Yeah, now it's coming up. It's coming up.
Now it's in?
Yeah.
Yes.
Yes, ma'am. We are seeing
Make
that.
it full screen. Yeah.
So first of all, I must thank NUCD, the organizers, Dr. Das and Jayant and Dr. Kanungo. So Dr. Kanungo and Professor Das has been very kind to me for the past 16 years. I have been attending this meeting and participating. So good evening, everyone. I'll be talking on understanding the diabetic amyotrophy. As Dr. Sahai said, this is really rare. So I'll start with a case presentation. So there is a 49-year-old man who came with left buttock pain and left leg pain, who was planned for a spinal cord decompression surgery. And he had acute burning pain, which was radiating down from his left buttock to the left lateral leg. And he also noted significant weight loss, about more than 13 kgs. And on examination, he had decreased muscle bulk of the left thigh, decreased strength of the left hip, left knee flexors, and as well as the extensors. And MRI scan was done, and it showed mild canal narrowing with cord flattening in the lower thoracic spine. And biochemistry revealed severe hyperglycemia, and EMG was also done. He had evidence of acute and chronic denervation in the lower extremity muscles, which was consistent with diabetic amyotrophy in the setting of a newly diagnosed diabetes mellitus patient. So finally, he was diagnosed as a case of diabetic amyotrophy, and he was started on basal bolus insulin regimen, and patient improved and surgery was cancelled. So this case report describes a typical case of diabetic amyotrophy, which is a very rare neurological complication of diabetes mellitus, and this also can mimic the spinal cord stenosis and does not require surgery. So this is the moral of this case. So on follow of this patient, the patient's surgery was cancelled and the endocrinologist was consulted, and all serological parameters of autoimmune diabetic disease was done, and they were all negative, and patient was discharged with basal bolus insulin regimen. After 2 weeks, the blood sugar was good, and he reported improvement in the leg pain and also weakness. So let us have a look at about this entity. So this entity, that is diabetic amyotrophy, was first recognized by Leiden in 1877. The original description, we call it as a diabetic lumbosacral radiculoplexus neuropathy. This was attributed to Bronze in 1890. And later it was termed as diabetic amyotrophy by Hugh Garland, that was 1950. And this is also known as Burns-Garland syndrome. Also we call it as proximal diabetic neuropathy, diabetic mononeuritic complex, multiplex, and paralytic neuropathy. And Burns-Garland also described 12 patients who had presentation like asymmetrical, progressive, and diffuse lower extremity pain with motor weakness, which was accompanied with muscle wasting, weight loss, and also areflexia. So it had clear relation to the recent onset diabetes and also uncontrolled diabetes, and complete recovery was found with appropriate glycemic management. So let us have a look at what is the pathophysiology of this entity. So mechanism, although it is still a subject of debate, but there are evidences that probably this disease is because of the ischemia, metabolic derangements, and inflammatory etiologies. Probably it is an autoimmune mediated inflammatory state resulting in vasculitis, and that causes ischemic nerve injury. It also has been documented that probably there are abnormal sphingolipid metabolism, which has a critical regulated role in the immunity as well as inflammation, and which could explain the pathogenic mechanism for the injury. And nerve biopsy also has shown that there are degenerative changes secondary to microvasculitis, with ischemia and inflammation further ratified by elevated CSF protein. And neurophysiological studies, they have shown that a multifocal process which involves the lumbosacral plexus, nerve roots, and the peripheral nerves, peripheral denervation changes. All these mechanisms was because of this, diabetes. So what is the presentation of the disease? So mostly this occurs in the setting of diabetes mellitus, so mostly in elderly age group. The median age of presentation is about 65 years. Normally this patient, they present as a subacute presentation, and there is progressive course, and often their unilateral neurogenic process that occurs in the setting of diabetes. The distinctive history of the unilateral neuropathic pain is there, which is followed rapidly by atrophy of the muscles and also weakness. And this complication most commonly occurs in cases of well-controlled diabetes mellitus, and there is significant weight loss in almost all patients, and there is also areflexia, which is present in most cases, and even in some patients, they can progress to paraplegia. Clinically active for a relative short period, so that means it has a self-limiting course, and it patient can recover even in within 2 years of its onset. There is progressive worsening of the disease with gradual recovery, but with some decrement if impairment may be there. In contrast to the diabetic peripheral neuropathy that we normally see in day-to-day practice, this diabetic amyotrophy, they are often having a newly diagnosed diabetes in the background, and there is short period of exposure to hyperglycemia. They are having a better glycemic control than the diabetic peripheral neuropathy. They are less associated with other diabetic associated complications like all microvascular as well as macrovascular complications. But at the same time, these patients, they are thin built, they are having lower BMI than the average diabetic population. So these are all differentiating points that you can differentiate this entity from the diabetic peripheral neuropathy. You can also find other findings like the patient can have numbness, tingling sensation, paraplegia, quadriplegia. There is also change in sweating. There can have foot drops also, having features of dysautonomia in the form of like orthostatic hypotension. Patient can have diarrhea, constipation, and also change in sweating. And this is basically by the diagnosis is basically by exclusion only. So it occurs both in type 1, type 2 diabetes mellitus, but type 2 diabetes mellitus patient, they have a relatively higher prevalence than the type 1 diabetes mellitus. So here is a prospective study of 33 patients with diabetic amyotrophy patient, and 21% of these patients, they presented with this neuropathy as the first symptom of their underlying disease. And most severe symptoms were at the onset were pain, that was about 82%, weakness was present in 80% of the cases. They were mostly distributed in the proximal musculature, that includes hip, thigh, buttock, and the back. Symptomatic treatment that improves the quality of life, that can be sufficient, but there are also thoughts that early use of immunomodulators in the form of steroids, maybe IV immunoglobulin, that has been proposed as a superior therapy. However, the patient, this disease has a self-limited course. So this is I just got the case series that is about 113 cases from the European Medical Journal. So I'm just delineating all the symptoms. The cardinal symptoms included the abrupt onset of the severe proximal leg pain in thigh, hip, back, and followed by progressive weakness and atrophy within weeks. And pain was unilateral in 70% of cases, but whenever it was bilateral, it was usually asymmetric, and minority of the cases they complained of symmetric back and leg pain, and the pain was characterized by deep arcing tingling sensation with or without burning. Proximal muscles were more involved than the distal muscles, most characteristic sign accompanied by various muscle atrophy, and distribution of weakness and atrophy was unilateral in 25% cases, but maybe it is bilateral in 50% of the cases. Overall, the involvement of the other leg occurred in approximately half of the cases, typically within 6 months. A small number of cases, they progressed to severe quadriparesis, and sensory loss was common but revealed symmetrical. It is not asymmetrical. 20% of cases, they had dysautonomia in this series, and majority had areflexia prior to the onset of diabetic amyotrophy. 50% of the cases, they had clinical evidence of diabetic polyneuropathy at the initial evaluation. So basically, the diagnosis is mostly based on clinical findings in a recent onset diabetes mellitus. Laboratory investigation, you can do like biochemistry tests, including HbA1c, liver function, electrolytes, including CRP and ESR. Of course, diagnostic studies in the form of CT, MRI, EMG, they are also required, but biopsy has no role. Even you can go for a CSF evaluation, because majority studies, they have shown that there is elevated protein levels, pleocytosis, suggesting inflammation in the CSF. So next, this is the findings in the electrophysiological studies. In the NCB, they have found that asymmetrically reduced sensory and motor action potential amplitude in most of the affected muscle sites, and EMG showed widespread patchy involvement, fibrillation potentials, and high amplitude motor unit potential. Imaging showed that that is X-ray, CT, MRI suspecting the compression useful for exclusion. So you have to exclude other conditions that causes such kind of neurological symptoms. In MRI, T2 signal can increase with varying severity, and biopsy is described extensively to aid for the diagnosis, but this is not an integral part for the diagnosis. So what are the differential diagnosis? As I said, the diabetic peripheral neuropathy is one of the most important differential. Apart from that, we have nerve root compression. You have to rule out that infiltrative pelvic malignancy, CIDP, vasculititis, sarcoiditis, other infections, and post-radiotherapy. These all has to be excluded. But most important differential that should be excluded is the condition that is called as diabetic muscle infarction or diabetic myopathy. I just discussed about this condition, having MRI patterns and the current trends I found in one of the article. So this is a condition that is typically present with abrupt onset of pain and swelling of affected muscles. So this has to be excluded. This has to be differentiated from diabetic amyotrophy. This is most frequent among type 1 diabetes patients, but however, in this series, type 2 diabetes patients are more prevalent. So it's a spectrum of disease having muscle inflammation, ischemia, hemorrhage, infarction, necrosis, fibrosis, as well as fatty atrophy. So it is seen with long-standing diabetes and also poorly controlled diabetes mellitus. So you will find a palpable painful mass which was present in 34 to 44% of the patient. Fever was present in 10% of the patient, associated with high incidences of diabetic complications, unlike diabetic amyotrophy. So this is associated with all complications. Diagnosis is very important with typical clinical presentation and MRI findings so that potentially harmful biopsies should be avoided. So MRI reports in this study in this series was actually collected, that is on the lower extremities, and collected from July 1999 to 2006 and reviewed and compared with clinical parameters for patients with diabetic myopathy. Clinical parameters like types of diabetes, A1C, CK level, ESR level, presence of complications including nephropathy, neuropathy, retinopathy, they were all noted, and the distribution of muscle involvement imaging features were also reviewed. So what was found in this series was that, just a minute, 16 patients were imaged over a period of 79 months and period 2020, including 21 extremities, that means 11 thighs and 10 calves. 88% patient had type 2 diabetes mellitus and only 12% had type 1 diabetes mellitus. 4% had disease in more than one location. Anterior compartment of thigh was more involved in all patients. Muscle infarction, necrosis was seen 8%. And the creatine kinase level, ESR, A1C level, they were all elevated in majority of the patient. Coexisting nephropathy, neuropathy, and retinopathy was present in a significant number of patients. The imaging findings in this series was found that there was subcutaneous edema, which was present in all thighs, that was 100 patients, and subfacial fluid was present in 91 patients in thigh as well as the calf muscles. And MRI finding was that there was pattern of diabetic muscle ischemia, there was ream of enhancing patterns of muscle infarction and necrosis was found, and hemorrhagic infarction also were found. Muscle necrosis and hemorrhage was seen in T1 weighted images, appeared as areas of hyperintensity within the affected muscle on T2 images. So you can see here the muscle ischemia, diffuse edema, subcutaneous edema, and myocyte necrosis in the thigh muscle, and also you can see here type 1 diabetes mellitus with bilateral myopathy of its thigh showing muscle ischemia and subcutaneous edema. So next, let us discuss about the treatment of diabetic amyotrophy. Obviously, the glycemic control is the key to treatment, and with symptomatic management, prognosis is always good, and the treatment is centered on symptomatic management. Pain management is a must, and management of hyperglycemia. Improvement in mobility is required, and pain management you can do with simple paracetamol or NSAIDs. Amitriptyline at night can be given. Selective serotonin receptor inhibitors are choices of treatment. Also, in severe cases, you can opt for opiates, and also sometimes if there is no pain relief, you can also use steroids. we can consider in severe diseases. A hospitalization is required if pain is not remitted. So we can contemplate for hospitalization in case of unremitting pain. So let us have a look at what is the role of steroid in such kind of cases. When we give a steroid, then the diabetes will also be uncontrolled. So there are multiple small studies who have demonstrated improvement of patient outcomes with the use of immunosuppressants in the form of like steroids, immunoglobulins, and also plasma exchange, but clear evidence is still lacking. Role of steroid in a double-blind study, including 75 patients who compared the high-dose steroid, weekly dose of 1 gram methylprednisolone for weeks versus the placebo. What was found that in the primary endpoint of motor improvement was not there, but the secondary endpoint in the form of the neuropathic pain was improved in this group. And steroid are considered particularly in those cases who are having severe pain just for the pain relief. Then next comes the role of immunomodulators. In 1995, there was a study by Crandall et al. Who reviewed the response to treatment of 15 patients with proximal axonal diabetic neuropathies. When IV immunoglobulin was given, it showed benefit in the strength, and however, most of these patients, they also received steroid orally or intravenously. Other kind of treatments in the form of cyclophosphamide as a thioprim as a steroid-sparing agent. Sometimes, some cases also, they use the plasma exchange, and most patients using all these therapies, they improved, including 4 of the 5 plasma exchange patients and 2 of 3 intravenous immunoglobulin treatment. So what was seen that all exhibited improvements in their pain and neuropathy disability scores. However, the primary pathology was not changed. So other complication also we have to look for. So patient can land in paraplegia, patient can have quadriplegia in the long run, patient can have depression, anxiety, and unnecessary spinal surgery also in some cases can be done. So this is the prognosis. Overall prognosis is, I would say, is good and is expected for diabetic amyotrophy, as this is a self-limited process. It has a progressive course that tends to worsen progressively, followed by stabilization and ultimately complete recovery with some residual motor deficit. Rarely progression to quadriparesis has been reported with an unknown degree of recovery. So I would like to summarize my presentation. Diabetic amyotrophy is a rare complication of diabetes patient compared to the distal symmetric polyneuropathy. The distinct history of unilateral neuropathic symptoms followed by rapidly by atrophy and weakness is typical for this disorder, and the complication most commonly occurs in cases of well-controlled type 2 diabetes mellitus. While the underlying pathophysiology is unknown in most of the cases, but it is thought that probably there is a microvasculitic process is there. The diagnosis is often based on the clinical and electrodiagnostic grounds, and tissue biopsy is not typically performed. Symptomatic treatment, as I said earlier, and attempts at corticosteroid administration during immunotherapy should be carefully considered on those patients having severe symptoms. Better recognition is required for this disorder, which is likely to result in more rapid diagnosis, counseling, and finally, the referral system should be followed. Thank you very much for your kind attention.